Imagine this. A seemingly healthy young person, vibrant, full of life, suddenly collapses without warning. No prior symptoms, no obvious illness, just a sudden devastating cardiac event. What if I told you that in many of these heart-wrenching cases, the subtle clues, the silent warnings were there all along, hidden in plain sight on a routine diagnostic test that many of us take for granted? Today, we're taking a deep dive into that fascinating and, frankly, life-saving world where a closer look at the heart's electrical language can unveil these hidden dangers. It's truly incredible what a few squiggly lines on a piece of paper can tell us, really. But before we truly plunge into today's deep dive, we want to extend a very special thank you to London Heartbeats Academy UK. Their invaluable educational support has really helped make this exploration possible. For anyone out there looking to deepen their understanding of cardiology or, well, any field really, they offer over 150 popular courses. You can find them on social media, Facebook, Instagram, and YouTube for free regular updates. That way you ensure you never miss out on future amazing discussions and insights like this one. And for those who want to take their learning even further, subscribing to their higher level YouTube membership gives you early access to educational videos and even personal chats and guidance sessions. They're an incredible resource for learners like you.
That's precisely what we're here to do. The electrocardiogram, or ECG, it's an absolute cornerstone of modern cardiology, no question. It's rapid, non-invasive, widely accessible, yet it holds secrets. Some of its patterns are incredibly subtle, quite atypical, and they can pose real diagnostic challenges, even for experienced clinicians. So our mission today is to extract the most important nuggets of knowledge from this complex material. We want to highlight their crucial clinical context, their characteristic findings, and the vital implications for diagnosis and management. These conditions, they span a wide range, from acute life-threatening emergencies that demand immediate attention to chronic electrical disorders needing careful long-term monitoring. Ultimately, we aim to enhance your awareness and recognition of these unique conditions, improving patient outcomes through timely and accurate diagnosis. Get ready for some serious aha moments, because the insights hidden in these ECGs are truly remarkable.
I'm ready to unpack this, and I know our listener is too. Let's get started with a powerful real-world example right off the bat. Imagine this scenario. A 10-year-old girl, seemingly the picture of health active, vibrant, full of energy, suddenly collapses during a school swimming lesson. There were no prior symptoms, no hint of illness, and her parents are, understandably, completely baffled. When the emergency team performs an ECG, the result sends a chill down their spines. A significantly prolonged QTC interval measuring over 500 milliseconds. What's even more striking is that further investigation reveals she also has congenital, profound, bilateral sensorineural hearing loss, a condition that had previously been attributed to other causes entirely. This combination, once connected, points directly to a rare but devastating condition called Jervell and Lange-Nielsen syndrome.
This case is absolutely critical because it highlights a profound truth in medicine: the need to connect seemingly unrelated symptoms. On their own, hearing loss and a fainting spell might be investigated separately, right? But when you see that combination of congenital deafness and a significantly prolonged QT interval on an ECG, it's a textbook example of Jervell and Lange-Nielsen syndrome. Timely recognition here isn't just important, it's literally life-saving. It guides clinicians to aggressive management strategies that can prevent fatal arrhythmias. It's like finding two puzzle pieces that, when put together, reveal a completely hidden picture. It's quite striking. 2-second quiet.
Okay, let's begin our deep dive then with long QT syndrome, often referred to simply as LQTS. You mentioned it in our opening case, and it's a condition where the heart's electrical system essentially takes, well, a little too long to recharge between beats. What exactly does that mean, or the heart's rhythm?
That's a perfect way to put it, actually. At its core, LQTS is a genetic heart condition. It affects how the heart's electrical system resets itself after each beat. Think of your heart's cells like tiny batteries that need to quickly discharge and then recharge to prepare for the next beat, right? In LQTS, this recharging phase, which we call ventricular repolarization, is abnormally prolonged. On an ECG, this shows up as a stretched-out QT interval. It's not super common, affecting about 1 in 2,000 to 1 in 2,500 individuals. Historically, researchers first started linking sudden cardiac death to prolonged QT intervals back in the mid-1950s. They noticed it particularly in deaf individuals, which later led to understanding different types or variants of the syndrome. It wasn't until the 1990s that specific genes responsible for these electrical issues were identified, and now we know of at least 17 genes that can play a role.
Right.
So it's quite diverse in its genetic origins.
So if we zoom into a cellular level, what's actually happening inside these heart cells that causes this prolonged recharge or reset time?
Okay, so the primary cause boils down to faulty electrical gates in the heart cells. These are tiny structures called ion channels, and they're responsible for the precise flow of electrically charged particles, like potassium and sodium, in and out of the cell. In about 95% of LQTS cases, the problem is with the potassium channels. Imagine these channels are like gates that should open and close at specific times to let potassium flow out and help the cell reset. In most LQTS types, these potassium gates don't open properly or close too slowly, leading to a loss of function. This means the electrical reset takes too long. But here's where it gets particularly intriguing. One specific type, LQTS3, involves a different kind of malfunction. It's a gain-of-function mutation in the sodium channels. In this case, the sodium gates stay open a little too long, allowing too much sodium in, which also extends the action potential duration. All these alterations ultimately extend the time it takes for the heart muscle to repolarize, making individuals incredibly susceptible to dangerous, rapid, chaotic heart rhythms, especially a type called torsades de pointe, or TDP.
That makes a lot of sense. So what does this mean for patients? What symptoms should someone or, their family be looking out for that might suggest LQTS?
Well, the clinical picture can be quite varied. A large study of over 600 LQTS patients found that, surprisingly, only about 27% were symptomatic, meaning many people might carry the genetic predisposition without realizing it until, well, a critical event happens. When symptoms do appear, they often begin around 12 years of age. The most common manifestation is syncope, or fainting, occurring in about 60% of untreated patients. Now, what's crucial to understand is that syncope in LQTS is quite distinct. It's often very sudden, without any of the usual warning signs like feeling lightheaded or heart racing or dizzy. Instead, episodes might be associated with apnea, a temporary stop in breathing, or even a bluish tint to the skin, and sometimes seizure-like movements. This just underscores the absolute importance of a detailed personal and family history. If there's any family history of sudden death, unexplained drownings, or even mysterious car accidents, it should raise a red flag immediately.
So the ECG is truly the cornerstone of diagnosis then. How exactly do doctors use it to pinpoint LQTS, especially with all these nuances we're talking about?
You're absolutely right. The ECG is foundational. The first step is always to rule out acquired causes, like certain medications that can prolong the QT interval. That's actually a very common cause of this phenomenon. Often, serial ECGs, meaning multiple readings over time, are needed for accurate diagnosis. The hallmark sign is a prolonged QTC interval. The C stands for corrected, because the QT interval naturally changes with heart rate, so we use formulas to adjust it. We typically measure from the start of the QRS complex, that's the heart's main contraction, to the very end of the T wave, which represents the heart's electrical reset. We usually look at leads 2, V2, or V3, averaging it over 3 Ds. A QTC over 460 milliseconds in females and 450 milliseconds in males is a key indicator. Now, what's fascinating here is that while a standard ECG is vital, a 24-hour Holter monitor can also be incredibly helpful. This small, portable device records your heart's electrical activity over a full day, assessing dynamic changes in the QTC, especially during sleep or recovery. Other suggestive ECG findings include inverted T waves, T wave notching, and something called T wave alternans, or TWAs. TWAs are a subtle beat-to-beat variation in the shape or amplitude of the T wave, and they are a significant warning sign, alerting clinicians to a heightened risk of lethal arrhythmias. Also, brief pauses in the heart's rhythm, known as sinus pauses, can be an alarming sign, particularly in the LQT3 subtype. The most common life-threatening arrhythmia we see is torsades de pointe, or TDP, which literally means twisting of the points. It's a rapid polymorphic ventricular tachycardia that looks like a ribbon twisting around the baseline on the ECG, often triggered by a short sequence of heartbeats. Very distinct pattern.
Okay, beyond the standard ECG, what other tests help pinpoint LQTS and maybe guide treatment?
Right, so while a 24-hour Holter can detect transient QT prolongation, it's not considered the single gold standard. For long-term monitoring, implantable loop recorders can be invaluable. They quietly track heart activity for extended periods. There are also specific challenge tests, like an adrenaline challenge test or a mental stress test, or even just doing an ECG when a patient goes from lying down to standing up. But these generally have lower diagnostic value compared to the core ECG findings in genetic testing. Speaking of which, genetic testing is absolutely crucial. It's strongly recommended for patients with a high Schwartz score. That's a scoring system doctors use to assess the likelihood of LQTS based on symptoms and ECG findings, or for asymptomatic individuals with a very prolonged QTC, and definitely for relatives of someone already diagnosed. This helps confirm the diagnosis and identify the specific genetic subtype, which can really influence treatment decisions.
So, how do doctors pull all this complex information together for a definitive diagnosis? Is there a kind of checklist they use?
Exactly. There are clear guidelines. An expert consensus statement on inherited arrhythmias outlines specific criteria. You can diagnose LQTS if a patient has a Schwartz score of 3.5 or higher and no other secondary causes like medication are found, or if their QTC interval is 500 milliseconds or more on repeated ECGs. Alternatively, a QTC between 480 and 499 milliseconds coupled with unexplained fainting episodes can also lead to a diagnosis. The Schwartz score itself is a point-based system. It considers clinical signs like fainting and deafness, and various ECG features like the QTC duration, the presence of T-wave alternans, or notched T-waves. More recent guidelines, like those from the European Society of Cardiology, even give extra weight to a resting QTC of 480 milliseconds or more and the presence of a confirmed genetic mutation. It really emphasizes the power of those genetic insights.
Okay, so once diagnosed, what's the path forward for managing LQTS? What do patients and their families really need to know about living with this condition?
Management really centers on risk stratification, figuring out who's at highest risk, and making crucial lifestyle adjustments. Invasive electrophysiological studies aren't typically the first step. Instead, we rely on the clinical picture, ECGs, and genetic information to identify those at highest risk for sudden cardiac death. Beta blockers are the absolute mainstay of therapy. They significantly reduce the risk of cardiac events by up to 60% and are generally recommended for all diagnosed patients. Beyond medication, lifestyle modifications are vital. For example, individuals with the LQT2 subtype should particularly avoid cold water immersion. And all symptomatic patients are usually advised to avoid competitive sports. Even asymptomatic individuals with confirmed genetic mutations need careful counseling. Other treatments exist, like potassium channel openers for LQT2 or mexiletine and ranolazine for those who can't tolerate beta blockers. For very high-risk patients, those who've had a cardiac arrest or keep fainting despite optimal therapy, an implantable cardioverter defibrillator, or ICD, is usually indicated. These devices can detect dangerous rhythms and deliver a life-saving shock. Pacemakers can help with very slow heart rates that might trigger QT prolongation. And in really tough, refractory cases, a procedure called left cardiac sympathetic denervation can be an option to reduce arrhythmia risk.
2-second quiet.
Now, let's turn our attention to Jervell and Lange-Nielsen syndrome, or JLNS. This is a truly rare but clinically devastating condition that's often considered a more severe form of LQTS, isn't it?
It absolutely is. JLNS is a rare genetic disorder affecting only about 1 in 1 million individuals. So very rare. Its hallmark characteristic is the co-occurrence of congenital sensorineural hearing loss, meaning hearing loss present from birth due to an issue with the inner ear or nerve pathways and a markedly prolonged QTC interval on the ECG. The condition arises because an individual inherits 2 copies of a mutated gene, one from each parent, making it an autosomal recessive disorder. These specific mutations lead to a much more severe form of LQTS. Individuals with JLNS face a significantly elevated risk of life-threatening arrhythmias like torsades de pointe, and these often manifest very early in childhood.
So what makes JLNS so severe and distinct compared to other forms of LQTS? What's going on at the genetic level that links the heart and hearing like that?
Right, the underlying problem in JLNS is a profound disruption of a specific electrical current in the heart, called the slow delayed rectifier potassium current. This is caused by mutations in both copies of certain genes, primarily KCNQ1 or KCNE1. Now, these genes are crucial not just for heart function, but also for the proper functioning of the inner ear's cochlear cells. In the inner ear, these electrical gates are vital for recycling potassium, which is essential for transmitting sound signals. When this process is impaired, it leads to profound hearing loss. And in the heart, the same faulty gates mean the heart cells take much longer to repolarize, leading to the extreme QTC prolongation we see. It's a double hit, affecting both systems. The clinical picture in JLNS is often quite serious and appears early. One study found that a striking 86% of individuals with JLNS develop symptoms, with 15% showing signs within their very first year of life. The vast majority indeed, most patients experience a major cardiac event, like a fainting spell, or even a cardiac arrest before they reached 18 years old. The most common triggers for these events are physical exercise and emotional stress. Swimming, as in our opening case, is a particularly frequent precipitant. It's also notable that very few events occur during rest or sleep for JLNS patients, unlike some other LQTS subtypes. Without appropriate intervention, the risk of mortality exceeds 50% by adolescents due to these life-threatening ventricular arrhythmias. It's incredibly serious.
How does the severe form specifically reflect on the ECG? Are there distinct markers unique to JLNS?
On the ECG, the key finding is a markedly prolonged QTC. We're talking about intervals typically exceeding 500 milliseconds that's significantly longer than what's often seen in the more common autosomal dominant forms of LQTS. The T-waves can also appear quite broad or notched, or even biphasic, with variations depending on the specific genetic mutation involved. Additionally, clinicians frequently observe bradycardia, or a slower than normal heart rate, which makes sense given the extended duration the ventricles need to repolarize. Beyond the ECG, audiometric testing consistently confirms a profound bilateral sensorineural hearing loss, which is, of course, a defining feature. You need that confirmation. And genetic testing is the definitive diagnostic tool, identifying those specific pathogenic mutations in the KCNQ1 or KCNE1 genes.
So how do doctors put all this together for a definitive diagnosis of JLNS? Is there a specific checklist for this one too?
Absolutely. The diagnosis of JLNS is established by a combination of key factors. A QTC interval that is consistently over 500 milliseconds, coupled with documented congenital bilateral sensorineural hearing loss. A family history that includes consanguinity, meaning the parents are related, or a sudden cardiac death, can also be a strong indicator. Finally, genetic confirmation of the specific KCNQ1 or KCNE1 mutations seals the diagnosis. It's interesting to note that the short score, which we mentioned for general LQTS, is less useful here because the presence of congenital deafness already provides a very strong diagnostic clue. It points you strongly in that direction. It's important, though, to distinguish JLNS from other forms of LQTS, like Romano-Ward syndrome, which doesn't involve deafness. Clinicians also consider other genetic syndromes that might present with hearing loss, as well as acquired forms of QT prolongation to ensure an accurate diagnosis. Treatment for JLNS primarily focuses on reducing the risk of arrhythmias and, crucially, improving the patient's quality of life. Beta blockers, such as propranolol and nadolol, are the first-line therapy because they help reduce the heart's excitability. For patients at high risk, particularly those with a history of cardiac arrest or recurrent fainting, an implantable cardioverter defibrillator, or ICD, is usually recommended. A truly vital aspect of management for JLNS patients is the use of cochlear implants. These can significantly restore auditory function and improve communication, which is huge for quality of life. Additionally, lifestyle modifications like avoiding medications known to prolong the QT interval and minimizing stressful stimuli are essential. While the prognosis without treatment is guarded due to the high risk of sudden death, timely and appropriate interventions can dramatically reduce mortality and improve long-term outcomes. 2-second quiet.
Okay, next, let's explore Romano-Ward syndrome, RWS. This is the more common form of inherited long QT syndrome, distinct from JLNS, right?
Indeed, RWS is the autosomal dominant form of LQTS. It's characterized by that prolonged ventricular repolarization, but without the extracardiac manifestations we saw in JLNS, like hearing loss or skeletal anomalies. Its global prevalence is approximately 1 in 2,500 individuals, so much more common than JLNS. And it shows significant variability in how it presents and its severity.
What's the underlying mechanism here? Still faulty ion channels?
Yes, fundamentally it's still about those ion channels. Mutations in up to 15 genes encoding cardiac ion channel subunits have been implicated. The most frequent occur in KCNQ1, which causes LQT1, KCNH2, LQT2, and SCN5A, LQT3. These are the big three. These genetic mutations prolong the action potential duration and delay cardiac repolarization, predisposing individuals to something called early after depolarizations. This mechanism significantly increases the risk of life-threatening arrhythmias, especially during periods of physical or emotional stress. The triggers for cardiac events are actually quite distinct across the RWS subtypes, which is fascinating. For LQT1, strong emotions and physical exertion, particularly activities like running or swimming, are common precipitants. In contrast, LQT2 shares these triggers, but also includes auditory stimuli like alarm clocks, sirens, or even just a phone ringing. That can be enough. Notably, about 40% of LQT2 patients may experience events during rest or sleep. For LQT3, the majority of cardiac events actually occur during sleep or rest. Aborted cardiac arrest or sudden cardiac death can be the initial manifestation in up to 10% of untreated patients, and the typical age of SCD differs by phenotype too.
How do these different subtypes translate into different ECG patterns? Can you tell them apart just by looking at the ECG?
Well, sometimes. Studies have shown mean-corrected QTC values varying by subtype, around 466 meters for LQT1, 490 meters for LQT2, and 496 meters for LQT3. So there are average differences. However, it's crucial to remember that up to 25% of genetically confirmed LQTS patients might present with a completely normal QTC interval. That's a real diagnostic challenge. T-wave morphology also varies by mutation. LQT1 can show normal, broad-based, or even peaked infantile T waves. LQT2 often has lower amplitude T waves, sometimes with notching, and LQT T waves can be delayed in onset or appear sort of distant from the QRS complex. So there are clues, but not always definitive. The diagnostic approach for RWS is quite similar to that for general LQTS. It includes Holter monitoring to catch intermittent changes, and of course, genetic testing to pinpoint the specific mutation. The Schwartz score, which we discussed earlier, is considered the gold standard for initial risk stratification. It helps indicate the need for genetic testing, but genetic testing remains the definitive method for identifying the specific ion channel mutations responsible for RWS.
Differential diagnosis involves distinguishing RWS from other inherited conditions like Brugada syndrome, but also, importantly, from acquired causes of QT prolongation. Things like drug-induced QT prolongation, electrolyte disturbances like low potassium or magnesium, hypothyroidism, and even ischemic heart disease can mimic the ECG findings.
So what are the key strategies for managing Romano-Ward syndrome?
Management really prioritizes arrhythmia prevention. Beta blockers, especially propranolol or nadol, are commonly prescribed. They reduce cardiac events by lowering heart rate and sympathetic nervous system activity. For high-risk patients, an ICD may be considered. Avoiding QT prolonging drugs and sudden stressors is also critical. Patients need to be aware of medications to avoid. With proactive management, the prognosis is generally favorable, but regular follow-up and consistent lifestyle adaptations are absolutely essential, especially for those identified as high-risk individuals. 2-second quiet.
Now let's explore Anderson-Tawil syndrome, ATS. This one sounds really interesting, a rare condition that presents with a very specific triad of features.
That's right. ATS, sometimes called Andersen cardiodysrhythmic periodic paralysis, is another rare autosomal dominant channelopathy, estimated at 1 in 1 million. Very rare. It's historically classified as LQTS type 7, but it's really unique because it's characterized by that triad. Episodes of periodic paralysis, ventricular arrhythmias, and distinctive facial or skeletal dysmorphisms. It was first identified back in 1963 with further description of the classic triad by Ellen Andersen in 1971. Significant advancements came later, particularly from Romano-Tawil in 1994, hence the name Anderson-Tawil syndrome.
What causes this unusual combination of symptoms? Muscle weakness, heart rhythm problems, and physical features, how are they linked?
So ATS has an autosomal dominant inheritance pattern. Type 1, ATS1, which accounts for about 60% of cases, is caused by mutations in the KCNJ2 gene. This gene encodes the KARE2.1 inward rectifier potassium channel. This channel is vital for maintaining the resting membrane potential and for repolarization in cardiac myocytes or heart muscle cells. Mutations here reduce this potassium current, which prolongs repolarization and predisposes to ventricular arrhythmias. It also affects muscle function, causing the paralysis. Type 2, ATS2, comprises about 40% of cases, and these individuals lack KCNJ2 mutations. Its genetic basis remains uncertain, although another gene, KCNJ5, has been proposed. The electrophysiological hallmark is impaired potassium ion flow, leading to delayed repolarization. However, and this is key, unlike classical LQTS, QTC prolongation in ATS may be mild, intermittent, or even absent. The classic triad includes those arrhythmias, periodic paralysis, and physical anomalies. Cardiovascular symptoms commonly include palpitations and syncope, and disturbingly, sudden cardiac death has been reported in about 50% of patients. That's a huge risk.
Periodic paralysis typically presents at a very young age, often preceding cardiovascular symptoms by approximately 2 years. This paralysis and accompanying muscular weakness is not directly dependent on potassium levels, though it occurs more frequently in patients with hypokalemia, low potassium. The duration of these episodes is highly variable, sometimes lasting up to several days. Craniofacial anomalies include things like low-set ears, wide-set eyes, and a hypoplastic mandible, or small lower jaw. A long, narrow head shape called scaphocephaly has also been reported. Skeletal abnormalities include clinodactyly of the 5th digit, that bent little finger, sydactyly of the 2nd and 3rd toes, fused toes, and scoliosis, curvature of the spine. Not all individuals exhibit the full spectrum, though. Some neuropsychiatric associations like ADHD and depression have been suggested but are still unconfirmed.
Okay, given the potential for a normal QTC, what are the specific ECG clues for ATS that doctors should really be zeroing in on?
That's the critical point. Since the QTC might not be long, you need other clues. Studies identify several crucial abnormalities. Prominent U waves in leads V2, V4 are a big one. Bidirectional ventricular tachycardia is another very specific and dangerous rhythm. And frequent premature ventricular contractions, PVCs, are common. While there's ongoing debate about the QTC duration itself, earlier studies sometimes included the U wave in the measurement, suggesting prolongation. Many recent authors argue the QTC itself often remains normal, But the QU interval, measured to the end of that prominent U wave, is prolonged, averaging around 655 meters. Importantly, arrhythmias can occur independently of marked QT prolongation. One study showed 50% of patients had polymorphic ventricular tachycardia on Holter monitoring, underscoring the syndrome's arrhythmogenic potential regardless of the measured QTC. Beyond the standard ECG, additional investigations include Holter monitoring to detect arrhythmias, checking baseline and symptomatic blood potassium levels, and assessing thyroid function. While about 65% of ATS patients have a normal echocardiogram, others exhibit diastolic or systolic dysfunction. Electromyography, muscle MRI, and biopsy can help differentiate from other neuromuscular disorders. And of course, genetic testing can confirm the diagnosis and aid family screening.
So, how is ATS diagnosed definitively? What's the checklist?
Diagnosis is considered when at least 2 of 4 criteria are met. 1. Periodic paralysis. 2. Cardiac manifestations like those ventricular arrhythmias, a prolonged QTC, or prominent U waves. 3. Dysmorphic features, you need at least 2 specific ones like low-set ears, wide-set eyes, small mandible, 5th-digit clinidactyly or syndactyly. Or 4. A family history of confirmed ATS. It's important to differentiate ATS from other forms of LQTS like Romano-Ward and Timothy syndrome, and also from catecholaminergic polymorphic ventricular tachycardia, CPVT. As a genetic condition, there's no cure. Management focuses on symptom control. Arrhythmias, periodic paralysis, and syncope are treated with pharmacotherapy like beta blockers, calcium channel blockers, or flecainide. ICDs are indicated for patients with a history of cardiac arrest or sustained ventricular tachycardia. Periodic paralysis can be treated with carbonic anhydrase inhibitors like acetazolamide and potassium supplementation. Medications that prolong the QTC should definitely be avoided. Competitive or strenuous sports are discouraged due to arrhythmia risk, but light physical activity is actually encouraged, as it may reduce paralysis severity.
2-second quiet.
Next up, we have Timothy syndrome, or TS. This is also known as long QT syndrome type 8, another rare channelopathy known for its pretty widespread multi-organ involvement.
That's correct. TS is truly a complex disorder. It affects the heart, yes, but also presents with congenital heart defects, distinctive facial malformations, syndactyly, which is fused digits like fingers or toes, developmental delay, and even immunodeficiencies. Quite a collection of issues. It was first reported in Journey back in 1992 and later detailed by researchers including Catherine Timothy in 2004, hence the name.
Wow. What's behind these widespread effects? How does one genetic issue cause problems in so many different systems?
TS follows an autosomal dominant inheritance pattern, though interestingly, most cases are due to de novo mutations. That means they're new mutations in the affected individual, not inherited from parents. The disorder stems from mutations in the CCAN1C gene. This gene encodes the Cav1.2 L-type calcium channel. This calcium channel is absolutely crucial for calcium influx in the heart, in neurons, and in other excitable tissues throughout the body. That's why the effects are so widespread. The specific pathogenic mutations impair the channel's ability to inactivate properly. This leads to prolonged calcium influx, which in turn causes markedly prolonged ventricular action potentials and, consequently, very long QTC intervals. There are actually 2 types. TS1 results from mutation in a specific part of the gene called exon 8A, and TS2 from mutation in exon 8. Some research suggests TS2 might have a more severe prognosis because exon 8 is expressed much more frequently in cardiac and neural tissues. Clinically, patients with TS are often born prematurely, sometimes due to fetal bradycardia detected before birth.
They are also highly vulnerable to general anesthesia, with multiple reports of cardiac arrest during surgical procedures. That's a major concern. Syncope has been reported in about 70% of patients. TS1 is characterized by distinct craniofacial features, including a receding hairline, a rounded facial structure, an underdeveloped jaw, a flattened nasal bridge, a thin upper lip, and a predisposition to dental caries or cavities. TS2 shows more variability but often shares the receding hairline, flattened nasal bridge, and thin upper lip. Syndactyly, that fusing of digits, is unique to the classical TS1 phenotype. Neurologic manifestations are common, including speech delay, impaired communication, and ataxia, which is a lack of muscle coordination. Immune dysfunction leading to recurrent infections and problems with low blood sugar, hypoglycemia, have also been reported. It's a truly multi-system disorder.
What does the ECG reveal specifically for Timothy syndrome? What are the key electrical signs?
All TS patients exhibit prolonged QT intervals. The QTC typically exceeds 480 meters in TS1 and sometimes surpasses a staggering 600 meters in TS2. Very, very long. One study found that almost half, 47% of patients, had a 2.1 atrioventricular block, meaning only every second electrical impulse from the atria gets through to the ventricles. About 6% experienced bradycardia due to sinus pauses. Additionally, 47% displayed T-wave alternance, that warning sign we discussed earlier, associated with leaky arrhythmias. Life-threatening arrhythmias like ventricular tachycardia, ventricular fibrillation, and cardiac arrest have all been reported in TS patients. Echocardiographic findings, mostly from case reports due to the syndrome's rarity, describe structural abnormalities. Things like patent ductus arteriosus, patent foramen oval, ventricular septal defects, and even tetralogy of Fallot have been seen. Left ventricular hypertrophy has also been noted, though some cases do show a structurally normal heart. Genetic testing for the specific HERO-CID-A1C mutation is crucial for diagnosis.
Is there a consensus for diagnosing this incredibly rare condition?
While there isn't a formally established consensus like for some other syndromes, diagnosis is typically based on a combination of factors. The characteristic craniofacial features and syndactyly in TS1 are important clues. Specific ECG findings are key, particularly that extreme QTC prolongation, over 480 meters in TS1, often over 600 meters in TS2, the 2.1 AV block, and a history of lethal ventricular arrhythmias or cardiac arrest. And finally, identifying a pathogenic mutation in the CACNA1C gene, specifying exon AA for TS1 or exon A for TS2 is definitive. Differential diagnosis includes Anderson-Tawil syndrome, Jervell and Lange-Nielsen syndrome, and other forms of long QT syndrome that might share some features. Data on the effectiveness of medical therapy is unfortunately limited due to the rarity. Beta blockers have been used but require cautious administration and careful monitoring for hypoglycemia, as they can mask the symptoms of low blood sugar, which these patients are prone to. Other antiarrhythmic treatments like calcium channel blockers, mexalotine, and ranolazine might potentially reduce arrhythmogenic risk, but more research is needed. Surgical correction is advised for any structural heart defects.
Due to the extremely high mortality risk associated with Timothy syndrome, ICD implantation is considered essential, even in asymptomatic patients. Pacemakers are also recommended for those with significant bradycardia or sinus pauses. It requires very aggressive management. 2-second quiet.
Okay, we spent a lot of time talking about long QT syndrome, where the heart's electrical recharge takes too long. Now let's completely flip the script and talk about short QT syndrome. It's rare, but just as dangerous, isn't it?
Absolutely. It's the mirror image, and equally, if not more, dangerous in some ways. Short QT syndrome, or SQTS, is another rare, genetically determined, autosomal dominant cardiac channelopathy. But instead of a prolonged electrical reset, it's characterized by a markedly shortened QTC interval on the ECG. The heart recharges far too quickly. This incredibly rapid repolarization significantly raises the risk of life-threatening arrhythmias and sudden cardiac death. The first reports linking a shortened QTC to an elevated risk of SCD emerged in 1993, and its genetic underpinnings were further clarified in 2000. It's a very intriguing condition because it defies the conventional understanding that a faster heart reset would be better.
So if long QT is about delayed repolarization, what causes the heart to recharge too quickly in short QT syndrome? What are those faulty electrical gates doing this time?
In SQTS, the problem is also with those tiny electrical gates, the ion channels, but the effect is the opposite. Instead of slowing down, they speed things up. In some subtypes of SQTS, specifically SQTS 1 through 3, there's a gain-of-function mutation in potassium channels. This means these potassium gates open too wide or stay open too long, causing potassium to rush out of the cell much faster than it should, abruptly shortening the electrical action potential. It's like a circuit breaker tripping too quickly. In contrast, SQTS 4 through 6 involve loss-of-function mutations in calcium channels. Here, the calcium gates don't let enough calcium into the cell, which also contributes to that rapid repolarization and action potential abbreviation. There's even a novel subtype linked to mutations in a cardiac chloride bicarbonate exchanger. The overall result is a severely shortened QTC, very brief effective refractory periods, meaning the heart can be re-excited too soon after a beat, and increased transmural dispersion of repolarization, creating a perfect substrate for reentrant arrhythmias. It's genotypically and phenotypically heterogeneous, with 7 subtypes identified so far.
The clinical picture for SQTS is quite stark. About 40% of patients might be asymptomatic, meaning they have no obvious symptoms until a catastrophic event. Among those who do show symptoms, cardiac arrest is frighteningly the most common initial presentation, occurring in 28% of cases, and it's also the most frequent symptom overall, with a prevalence of 34%. Sudden cardiac death occurs in about 4% of patients during the first year of life and shows 2 incidence peaks, one in infancy and another between the 3rd and 5th decades of life. Other notable manifestations include palpitations, dizziness, and syncope. Triggers vary by subtype. For example, SQTS1 patients often have events triggered by exertion and emotional stress, while SQTS3 has been associated with nocturnal palpitations. Interestingly, a systematic review revealed that the incidence of cardiac events in SCD and SQTS patients is significantly higher among women.
How does this rapid recharge manifest on the ECG, and are there any nuances to its measurement that make it tricky to spot?
That's a great question, because it's not just about a short QTC. It's also about how it behaves. A key characteristic of SQTS on the ECG is that the QTC interval remains relatively constant, regardless of heart rate changes. This is quite unusual. Normally, the QT interval prolongs when your heart rate slows down and shortens when it speeds up. But in SQTS, the QTC shows inadequate prolongation during bradycardia and excessive shortening during tachycardia, a phenomenon we call pseudonormalization. This distinctive pattern is a huge diagnostic clue, especially when confirmed with serial ECGs, Holter monitoring, or treadmill testing. For optimal accuracy, experts recommend obtaining ECGs at a heart rate of approximately 60 BPM. Additional ECG findings include the shortening or even absence of the ST segment, tall and peaked or sometimes biphasic T waves, and prominent U waves. Atrial fibrillation, premature ventricular contractions, ventricular fibrillation, and cardiac arrest may occur as direct manifestations. Beyond the basic ECG, treadmill stress testing may reveal a QTC that remains unchanged or shows minimal adaptation to heart rate variations, with a QT-HR slope less than 0.9 meters Speedman. Advanced echo techniques like speckle tracking and tissue Doppler imaging might reveal impaired systolic activity. The role of electrophysiological studies remains controversial. Some studies report brief refractory periods and susceptibility to induced arrhythmias, but they don't reliably predict SCD risk. 7 genetic mutations are linked, but the genotype-phenotype correlation remains unclear due to the limited number of confirmed cases.
Is there a specific scoring system for SQTS like there is for LQTS?
Yes, there is. The short score for SQTS, proposed by Velman and colleagues, combines ECG findings, clinical history, family history, and genetic testing. Points are assigned for QTC duration, for example. A QTC under 370 meters earns 1 point, under 350 meters 2 points, and under 330 meters 3 points. Clinical criteria include cardiac arrest or polymorphic VTVF, 2 points each, and family history considers relatives with likely SQTS or sudden infant death, 1 over 2 points. At least 1 ECG point is required for other criteria to apply, making the ECG absolutely central to the diagnosis. It's important to distinguish SQTS from Kubota syndrome and early repolarization syndrome, which can have similar ECG features. Careful differentiation is key. ICD therapy is the cornerstone of management, especially for symptomatic patients or those with a positive family history or supporting findings from other tests. It's crucial to understand that a negative genetic or electrophysiological study doesn't rule out the diagnosis or future risk. Pharmacological therapy, such as quinidine, is considered most effective as it prolongs the QTC and ventricular refractory periods.
Disopyramide is also a viable alternative, particularly for SQTS1. Other antiarrhythmic agents have generally shown limited efficacy, and certain drugs like abulide and sotalol have been shown to be ineffective. 2-second quiet.
Okay, from these complex genetic predispositions, let's pivot to something a bit more mechanical, maybe. Twiddler syndrome. This sounds almost whimsical, but I gather it's a serious pacemaker malfunction.
It does sound a bit lighthearted, doesn't it? But yes, it can be very serious. First described way back in 1968, Twiddler syndrome results from pacemaker malfunction because the patient themselves, sometimes consciously but often unconsciously, manipulates or twiddles the pulse generator under the skin. This repetitive movement causes coiling and malpositioning of the pacemaker leads, typically within the first 12 months after the device is implanted. Its prevalence has been estimated at about 1.2% in high-volume centers, so it's not incredibly rare.
So the patient is inadvertently causing their own pacemaker problems by fiddling with the device.
Essentially, yes. One review found that patients receiving antidepressants were actually more prone to manipulate the pacemaker. While many patients might adjust the device occasionally, maybe to check its position or alleviate some discomfort, most stop over time. However, sometimes patients, particularly those with certain psychiatric conditions, might persist. Another significant risk factor is a discrepancy between the size of the pacemaker pocket created during surgery and the device itself. This is particularly evident in obese patients, as the larger pocket allows more room for the device to move around and potentially be twiddled. Clinically, you might see skin abrasions at the site of manipulation. More seriously, the lead displacement can cause various symptoms. Most frequently, it causes phrenic nerve stimulation, which leads to hiccups or diaphragmatic contractions. Or patients might feel abdominal pulsations or rhythmic arm twitching if the brachial plexus gets stimulated. Critically, the pacemaker dysfunction resulting from this can lead to fatal arrhythmias and even cardiac arrest if the heart relies on the pacemaker.
How does this manifest on an ECG then? What would you see?
Well, the ECG findings really depend on why the pacemaker was put in and how it's programmed. They can range from completely normal readings, if the patient isn't pacemaker dependent at that moment, to complete heart block with loss of capture, meaning the pacemaker fires but doesn't stimulate the heart muscle. Notable signs include the absence of the expected pulse generator artifacts, the little spikes on the ECG, loss of capture, inappropriate pacing, pacing when it shouldn't, abnormal pacing morphology, the shape of the pace heartbeat looks wrong, irregular pacing intervals, and asynchronous pacing, pacing at a fixed rate unrelated to the heart's own rhythm. In cases involving ICDs, the loss of adequate sensing and capture can lead to even more dramatic ECG findings, including failure to treat malignant ventricular arrhythmias or, conversely, inappropriate shocks, and potentially even a systole. The main pillars of diagnosis are the ECG and a chest X-ray. A chest X-ray typically reveals displacement of the lead, often appearing coiled up near the generator device itself. You literally see the wires twisted. Additionally, pacemaker interrogation, checking the device's internal data using a programmer, can identify dysfunction, like high pacing thresholds or sensing problems. It's important to distinguish Twiddler syndrome from something called Real syndrome. Real syndrome is a similar issue but results from inappropriate anchoring of the leads during the implantation surgery itself, where the generator basically spins around its long axis, winding the leads around it. Different mechanism, similar result.
How do you fix this once it's identified?
Treatment requires reoperation. The surgeon needs to reposition the lead securely and often needs to apply additional sutures to anchor the generator tightly to the fascia within the surgical pocket to prevent it from moving again. Patient education is crucial, explaining why they shouldn't manipulate the device. And in some cases, particularly if there's a compulsive element, a psychiatric evaluation might be necessary to help prevent recurrence. 2-second quiet.
Moving from a mechanical issue back to a multifaceted genetic condition, let's explore Noonan syndrome, NS. This one affects multiple organ systems, right?
It absolutely does, and it's quite common for a genetic disorder with an estimated incidence of 1 in 1,000 to 1 in 2,500 live births. NS is characterized by a specific constellation of features: short stature, distinctive facial characteristics, developmental delays, and crucially, cardiovascular abnormalities, including congenital heart defects. Initially, it was sometimes called male Turner syndrome, but is correctly redefined in 1963 by Noonan and MK as its own distinct disorder.
What's the genetic root of such widespread effects? How does it impact so many different parts of the body?
NS arises from a disruption of the rasmaparinase signaling pathway. Think of this pathway as a critical communication network within cells, triggered by various factors and essential for organ development, synaptic adaptability, and cellular growth. It's fundamental. It's caused by mutations in several genes involved in this pathway, with 80–85% of cases attributed to genes like PTPN11, SOS1, RAF1, and CREAS, among others. Because this pathway is so central to development, disrupting it has these broad effects. It's an autosomal dominant disorder, often from new mutations. Clinically, hearing abnormalities are present in about 25% of patients, mainly affecting high frequencies. Congenital heart disease affects up to 90% of NS patients. That's a huge proportion. The most common heart defects are pulmonary valve stenosis, affecting 25–75%, and atrial septal defects, seen in 4–57%. Other abnormalities include ventricular septal defects, mitral valve defects, and aortic coarctation. The craniofacial features evolve with age. Infancy shows a prominent forehead, low-set ear, short neck. Toddlers may develop macrocephaly and a broad nasal bridge. Adolescence brings an inverted triangular face and webbed neck. Hair is typically fine and sparse in early childhood, often becoming curly later. Eye color is distinctively blue or green, and various ophthalmological abnormalities may be present. Infants may have feeding difficulties and developmental delays. Cryptorchidism is frequent in males, while females generally have normal fertility. Renal abnormalities, subtle bruising, and splenomegaly can also occur. It's really a head-to-toe condition.
Given the major cardiac involvement, what does the ECG tell us in Noonan syndrome? Are there specific patterns?
Yes. Patients with NS often exhibit distinctive ECG features. These include left axis deviation with a negative AVF, an abnormal RS ratio over the left precordium, meaning the relative sizes of the R and S waves are unusual, and abnormal Q waves. Historically, these were linked to heart rotation or structural defects. However, a key study by Rymakers and colleagues involving 118 patients demonstrated that while 58% exhibited a characteristic ECG pattern, they found no statistically significant relationship between these ECG abnormalities and underlying structural cardiac defects. This suggests these distinctive ECG features may arise independently of structural heart abnormalities, possibly due to the underlying RASMA pathway disruption itself. These ECG abnormalities are also more prevalent in infants and young children. For diagnosis, echocardiography is crucial, revealing things like left ventricular hypertrophy, LVH, and associated anomalies like pulmonary valve stenosis and mitral valve dysplasia. Certain echo findings can indicate prognosis. A comprehensive blood panel assesses thyroid function and coagulation factors.
Abdominal ultrasound is recommended due to splenomegaly risk, and renal ultrasound for kidney abnormalities. Regular ophthalmologic evaluations are essential. Genetic testing is vital to differentiate NS from other similar syndromes.
With so many features, how is NS definitively diagnosed? Is there a scoring system?
Yes, Vanderburg and colleagues established a diagnostic scoring system with major and minor criteria. Major criteria include characteristic facial dysmorphism, specific cardiac defects like pulmonary valve stenosis, short stature, chest deformities, and family history of NS. Minor criteria include suggestive facies and other cardiac abnormalities, developmental delay, cryptorchidism, and lymphatic issues. Diagnosis is confirmed with characteristic facial dysmorphism plus 1 major or 2 minor criteria, or suggestive facial features with 2 major or 3 minor criteria. It's a structured way to integrate all the findings. The differential diagnosis is broad, including Turner syndrome, fetal alcohol syndrome, mosaic trisomy 22, Williams-Beuren syndrome, Costello syndrome, and others that share phenotypic features. Management involves a comprehensive, multidisciplinary approach across various age stages. It includes screening of multiple organ systems, monitoring growth and development, and providing targeted treatments and interventions as necessary for heart issues, developmental support, feeding problems, etc. It's really coordinated care over a lifetime. 2-second quiet.
Okay, from complex syndromes to something once thought benign, but now recognized as a significant threat. Barlow's disease, linked to mitral valve prolapse.
That's right. Barlow's disease, or BD, is a clinical syndrome associated with mitral valve prolapse that was, for a long time, considered pretty benign. But we now recognize it as a significant cause of malignant arrhythmias and sudden cardiac death. While its overall prevalence is around 2–3% in the general population, it predominantly affects women, who also seem to have a higher risk of SCD associated with it, maybe up to 13% in some high-risk groups. Historically, its characteristic sound on auscultation, a non-systolic ejection click, was initially attributed to things like pleuropericardial adhesions. But in 1965, John Brereton Barlow and his team challenged this in a landmark article describing 7 clinical cases, correctly linking the condition to mitral valve prolapse. His findings were initially quite controversial, but eventually reshaped the clinical perspective entirely.
What's actually happening in the heart with Barlow's disease? What causes the prolapse and the arrhythmia risk?
BD is characterized by the superior displacement of the mitral leaflet, one of the flaps of the valve, by more than 2 millimeters into the left atrium during systole when the ventricle contracts. This prolapse results from pyromyxomatous changes in the mitral valve tissue itself. Basically, the tissue becomes thickened, floppy, and redundant. Now, when assessing the risk of sudden cardiac death, studies show that virtually all SCD victims with BD had evidence of fibrosis or scarring in the left ventricular papillary muscles, the small muscles that anchor the valve leaflets. And 88% also had fibrosis at the inferior base of the heart. This myocardial fibrosis is believed to be a key contributor to the arrhythmogenic potential, even when patients seem hemodynamically stable. The most common arrhythmic presentation is premature ventricular complexes, PVCs, followed by various forms of ventricular tachycardia and even ventricular fibrillation. A key mechanism behind the PVCs is thought to be stretch-induced depolarization due to the prolapsing leaflets pulling on the heart muscle.
Contributing factors include those fibrotic changes, excessive traction on the papillary muscles, increased sympathetic activity, and decreased vagal tone. Clinically, patients with BD commonly experience symptoms like chest pain, palpitations, exertional breathlessness, syncope fainting, and sometimes hypotension, low blood pressure. On auscultation, it's characterized by that late systolic murmur and a non-ejection systolic click. In a systematic review of SCD cases linked to Barlow's, 58% of patients experienced palpitations before their cardiac arrest, 28% were tragically asymptomatic, and in nearly half the cases, 47%, SCD was precipitated by physical or emotional stress.
How does Barlow's disease appear on an ECG? Are there specific electrical signs?
ECG abnormalities are actually observed in a majority of patients with mitral valve prolapse, maybe 58–89%. In those SCD patients with Barlow's, about 51% exhibited premature ventricular complexes on their prior ECGs, 24% had inverted T waves, usually in the inferior leads, and importantly, about 32% had a completely normal ECG before the event. On 24-hour Holter monitoring, PVCs and couplets, 2 PVCs in a row, were found in 63% of patients, while non-sustained ventricular tachycardia was present in 29%. So Holter is often more revealing than a single ECG. Cardiac imaging is absolutely crucial here. Transthoracic echocardiography and Doppler ultrasound evaluate the severity of the prolapse and any resulting regurgitation or leakage. Transesophageal echo might be needed for better views. Patients with a higher burden of ventricular arrhythmias more frequently exhibit bileaflet mitral valve prolapse, both leaflets prolapsing, and something called mitral annular disjunction, MAD, which is a separation between the valve annulus and the ventricular myocardium.
Certain echo markers like increased anterior mitral leaflet length during systole and the Bickelhaub sign
a specific high-velocity Doppler signal resembling a spiked helmet, are proposed markers for ventricular arrhythmia risk. Cardiac magnetic resonance, CMR, imaging further refines risk stratification. Late gadolinium enhancement, LGE, indicating fibrosis in the papillary muscles in the inferior and basal LV walls, is strongly associated with arrhythmogenicity. Shortened T1 mapping times on CMR, suggesting more widespread microscopic fibrosis, are another emerging marker.
What are the specific criteria for diagnosing Barlow's disease itself, perhaps histologically?
Yes, a set of macroscopic, visible to the eye, and microscopic histological criteria have been proposed for the valve tissue itself. Macroscopic criteria include ballooning or hooding of the mitral leaflets, arching of leaflets into the left atrium, enlargement of the leaflets, and an increase in the mitral valve area due to annulus dilation. Microscopic criteria involve enlargement of specific layers within the leaflet tissue, the spongiosa and fibrosa, deposition of fibrin and platelets, and changes in the atrialis layer where collagen fibers become compacted and disorganized. The primary differential diagnosis to consider is fibroelastic deficiency, which is another cause of mitral valve disease, but typically involves thinner, more fragile leaflets rather than the thick, redundant ones seen in Barlow's. Arrhythmia management remains challenging as ventricular arrhythmias often persist even after mitral valve repair surgery. Catheter ablation is recommended for symptomatic or high-risk ventricular tachycardia. Severe mitral regurgitation necessitates surgical intervention, repair, or replacement.
Some studies suggest that mortality due to ventricular arrhythmias might decrease after MV surgery if the mitral annular disjunction resolves. Following surgery, an ICD is a Class R recommendation, strongest recommendation, for patients meeting standard ESC guidelines for secondary SCD prevention, i.e. those who have already survived a serious event. The annual incidence of SCD is estimated at 0.20–0.4% in the general MVP population, but increases significantly, perhaps to 1.8%, in those with severe MNR due to leaflet flail. This underscores the need for lifelong follow-up, especially in high-risk patients identified through imaging and Holter monitoring. 2-second quiet.
Next, we delve into Danon disease, DD. This sounds like a metabolic disorder that affects not just the heart, but also skeletal muscle and the nervous system.
Indeed, Danon disease was first described in 1981. It was identified in two 16-year-old boys who presented with cardiomegaly, enlarged heart, myopathy, muscle weakness, and cognitive impairment. Initially, it was classified as a type of lysosomal storage disease because muscle biopsies showed excessive glycogen accumulation within lysosomes, which are like cellular recycling centers. However, its true underlying cause was clarified in 2000. It's not due to a faulty lysosomal enzyme, but rather a mutation in a lysosomal membrane protein called LMP2.
So what's happening genetically to cause these multisystem effects, heart, muscle, brain?
DD follows an X-linked dominant inheritance pattern. This means the causative gene is on the X chromosome, and because males only have one X chromosome, they are typically more severely affected than females who have two X chromosomes, one potentially normal copy. Some de novo mutations are also reported. The causative mutations occur in the LAMP2 gene. This gene encodes 3 protein isoforms involved in autophagy, the process of lysosomal protein degradation. All known pathogenic mutations affect the LAMP2B isoform, which is predominantly expressed in tissues like the heart, skeletal muscle, and brain. This explains its widespread effects across these systems due to impaired autophagy and cellular waste clearance. Symptoms tend to manifest earlier and progress more rapidly in male patients. Approximately 90% of affected males develop proximal muscle weakness, weakness closer to the center of the body, which gradually worsens, though it's usually not the primary cause of death. Myopathy appears to affect only about 35–50% of females. In one study, 88% of males and 77% of females were symptomatic. Palpitations were the most common symptom, followed by chest pain. Patients may also experience breathlessness, exercise intolerance, and fatigue. Sudden cardiac death has been reported. Mild cognitive impairment is observed in up to 70% of patients. Ophthalmological manifestations, including scotomas, blind spots, and blurry vision, have also been described. Additionally, over half of patients, particularly males, report respiratory and gastrointestinal symptoms.
What are the telltale ECG signs of Danon disease, maybe even early on before major symptoms appear?
This is a key point. ECG abnormalities are often present even before patients develop significant symptoms, serving as an important early indicator. A study found that 50% of males and 41% of females exhibited the characteristic shortened PR interval and delta wave of Wolff-Parkinson-White (WPW) syndrome on their ECG. WPW pattern is a common finding in many metabolic heart disorders. The ECG may also reveal abnormal Q waves, atrioventricular blocks, atrial fibrillation, inverted T waves, and notably pronounced signs of left ventricular hypertrophy, LVH. These LVH signs are often evident even in early stages, particularly in males. Severe arrhythmias like ventricular fibrillation, sustained ventricular tachycardia, and cardiac arrest have also been reported. The WPW pattern plus significant LVH should definitely raise suspicion for Danon. Paraclinically, DD patients often show elevated biomarkers like creatine kinase, CK, from muscle involvement and sometimes liver function enzymes, often up to 3 times normal levels. Echocardiography typically reveals left ventricular hypertrophy, often concentric, uniform thickening, usually with preserved ejection fraction initially.
This progresses to dilated cardiomyopathy over time. Interestingly, females may have asymmetric LVH and can present with either hypertrophic or dilated forms. CMR is valuable for assessing the extent of fibrosis and differentiating from other cardiomyopathies. In Danon disease, late gadolinium enhancement, LGE, tends to be diffuse, and importantly, the interventricular septum is usually spared, which can be a distinguishing feature. Electromyography, EMG, to assess muscle function and ophthalmologic assessments should also be performed. Genetic testing for LMP2 mutations is highly recommended for confirmation.
With so many possible manifestations, how do clinicians arrive at a diagnosis? Are there specific criteria?
Yes. Hong and colleagues proposed specific diagnostic criteria distinguishing between men and women due to the X-linked inheritance. For women, diagnosis requires a confirmed RMP2 mutation, plus at least one cardiovascular sign, such as ECG abnormalities like WPW or LVH, late gadolinium enhancement on CMR, LVH on echo, or an ejection fraction under 50%. For men, it requires a confirmed LMP2 mutation plus either one cardiovascular sign as above, or at least one muscular abnormality detected by EMG or elevated biomarkers, or at least one neurocognitive sign like attention deficit or developmental delay. Differential diagnosis includes other metabolic or muscular dystrophies like Pompe disease, Fabry disease, familial hypertrophic cardiomyopathy, Friedreich ataxia, and Duchenne muscular dystrophy. The combination of massive LVH, WPW, myopathy, and cognitive issues is highly suggestive of Danon. Currently, there are no specific guidelines for treating Danon disease itself. Management focuses on the consequences. Heart failure and arrhythmias should be managed according to existing standard guidelines.
ICD placement is recommended for symptomatic patients with non-sustained ventricular tachycardia and syncope, given the high SCD risk. Catheter ablation may be performed to treat the accessory pathway causing the WPW pattern. Heart transplantation is an option for end-stage heart failure, though some studies report poor outcomes in males, potentially due to systemic involvement, with death occurring within a year post-transplant in some series. 2-second quiet.
Okay, let's turn to BRASH syndrome. That acronym again for a condition that's relatively new to recognition but proves lethal in a significant number of cases.
Right, BRASH syndrome. It stands for bradycardia, renal failure, atrioventricular nodal blockade, shock, and hyperkalemia. It describes a clinical condition where the synergistic effects of AV nodal blockers, very common heart medications like beta blockers or certain calcium channel blockers, combine with acute kidney injury. This creates a vicious cycle of severe bradycardia and hyperkalemia. While the symptoms themselves were described as early as 1986, BRASH syndrome as a distinct entity has only recently been recognized and remains understudied. It's often mistaken for just simple hyperkalemia or maybe drug toxicity, yet it proves lethal in about 5.7% of reported cases. So recognizing it is crucial.
So it's a compounding problem. How does this destructive cycle begin and then perpetuate itself?
The pathophysiology involves an initial trigger. This could be something like dehydration, maybe an infection causing decreased intake, or even just an uptitration of an AD nodal blocking medication. This trigger leads to acute kidney injury, AKI. The kidneys falter, impairing potassium excretion, which results in hyperkalemia. The hyperkalemia then directly worsens the bradycardia caused by the AV nodal blocker. The drug is still there, but the high potassium makes the heart even more sensitive to its effects. This severe bradycardia reduces cardiac output, further worsening renal perfusion and function, which in turn worsens the hyperkalemia, and you get this downward spiral. A systematic review found that only 40% of BRASH patients had chronic kidney disease beforehand, meaning pre-existing renal dysfunction isn't a prerequisite. It can happen in people with normal kidneys if the trigger is strong enough. Most cases, 83% were precipitated by beta blockers, 45% by calcium channel blockers, and 23% by ACE inhibitors or ARBs, which can also contribute to hyperkalemia and AKI. Dehydration-induced hypovolemia is also a common trigger, particularly during hot months. Clinically, in that systematic review, the most frequently reported symptoms were related to cerebral hypoperfusion, reduced blood flow to the brain, things like syncope, lightheadedness, drowsiness, and encephalopathy. Additionally, 17% of patients experienced gastrointestinal symptoms like nausea or abdominal discomfort, while about 13% reported breathlessness. Chest pain was less common, perhaps underreported due to patients' altered mental status.
What are the key ECG findings here, especially given the hyperkalemia? Does it always look like typical hyperkalemia on the ECG?
That's a critical point because this is where BRASH syndrome can be misleading. Hyperkalemia alone can induce bradycardia, typically when potassium levels exceed 7.0 NEQL, and you expect specific ECG changes. Peak T waves usually appear around 5.5, 6.0 NEQL, then PR prolongation, QRS widening, and eventually a sine wave pattern as it gets very severe. However, in BRASH syndrome, the expected ECG changes of hyperkalemia are often absent or much less pronounced than you'd anticipate for the degree of hyperkalemia. Instead, the bradycardia is commonly associated with a junctional escape rhythm in 50% of cases, or sinus bradycardia in 17.1% and complete heart block in 12.9%. Atrial fibrillation or atrial flutter with a slow ventricular response may be present in about 10% of cases. This mismatch, severe bradycardia and significant hyperkalemia without the classic progressive ECG changes of hyperkalemia, is a key clue to BRASH. Laboratory markers are crucial, of course. That systematic review showed median potassium levels of 6.3 millirAQL, blood urea nitrogen, BUN 73 milligl, serum creatinine 2.8 millirNEL, serum bicarbonate 15 millirAQL indicating acidosis, and lactate 7.8 millirMOS.
These clearly show the renal dysfunction and severe electrolyte imbalance. It's really important to differentiate BRAH syndrome from isolated hyperkalemia or just intoxication with AV node blocking medications. The synergistic effect creating that vicious cycle is key to the diagnosis and explains why standard treatments for just one component might fail. Treatment needs to be aggressive and target multiple parts of the cycle simultaneously. Fluid resuscitation is needed to address dehydration and improve renal perfusion. Correction of hyperkalemia is urgent, using intravenous calcium to stabilize the cardiac membrane, plus insulin glucose, beta-agonists like albuterol nebulizers, and diuretics to lower potassium levels. Dialysis might be needed if these fail or renal failure is severe. Immediate management of the bradycardia is essential, often necessitating vasopressors with chronotropic effects, like epinephrine infusion. Transcutaneous or transvenous pacing might be required. Additional therapies like glucagon for beta blocker overdose and atropine have been suggested, but their effectiveness in BRAH is questionable. That review of 34 studies found them largely ineffective, with almost 60% of patients requiring inotropic or chronotropic support beyond these measures. This really highlights the severity and complexity of managing BRAH. 2-second quiet.
All right, let's move to Bungard syndrome. This is also known as familial ST segment depression syndrome, a newly identified inherited cardiac arrhythmia, right? Sounds quite specific.
It is very specific and very recently described. This autosomal dominant inherited cardiac arrhythmia was first identified only in 2018. It was documented through collaborative research involving 5 families from 3 different countries, making it a truly recent discovery in the field of inherited arrhythmias.
What's the mechanism behind this persistent ST segment depression? Is it structural or electrical?
Bungard syndrome exhibits an autosomal dominant inheritance pattern with high penetrance, meaning if you inherit the gene, you're very likely to show signs. However, the cause of the gene has not yet been identified. That's a key area of ongoing research. Histopathological examinations haven't revealed consistent structural abnormalities aside from some nonspecific fibrosis sometimes seen in cardiomyopathies, but nothing unique or explanatory. Recent studies using advanced techniques like Cine-ECG identified altered repolarization patterns localized specifically to the base of the left ventricle. Interestingly, researchers experimentally reduced the action potential duration and amplitude in these basal myocardial areas in healthy individuals, and this actually replicated the ST segment changes seen in affected patients. This strongly suggests a functional basis and electrical problem in a specific heart region rather than a gross structural one. Clinically, the ECG manifestations typically emerge during early adolescence. However, patients generally remain asymptomatic until approximately 50 years of age.
But they are predisposed to arrhythmias and commonly present later in life, with symptoms such as palpitations, syncope, cardiac arrest, or, tragically, sudden cardiac death.
What makes the ST segment depression in Bungard syndrome so distinctive on the ECG? How is it different from, say, ischemic ST depression?
Great question. In this syndrome, the ST segment depression is consistent and non-ischemic. That means it's not due to a lack of blood flow to the heart muscle like you'd see with a blocked artery. It shows no reaction to external factors like medication changes or improvement due to known influences. Instead, the depression typically worsens during physical activity, which is quite distinct. It is most significantly seen in leads 2, V5, and V6. One study found that 13% of affected individuals experienced atrial fibrillation, while another 13% had a history of aborted cardiac arrest or SCD. Ventricular arrhythmias were noted without any concurrent alterations in the QTC, ST segment, or T-wave morphology beyond the baseline depression, and they were mainly of a polymorphic nature. Paraclinical diagnosis involves looking for these patterns. Cardiac stress testing may reveal that persistent ST segment depression that worsens with exertion. Holter ECG is beneficial for evaluating the arrhythmic burden and for risk assessment. One study found that the majority of patients preserved a normal ejection fraction, though it was notably lower in men, with a quarter of male patients displaying EF under 50%.
Crucially, cardiac magnetic resonance imaging, CMR, reveals no specific structural abnormalities, reinforcing the functional electrical nature of the disorder.
How is this newly recognized syndrome diagnosed? Are there set criteria yet?
The proposed criteria include 1. Concave and upsloping ST segment depression greater than 0.1 milliV in at least 4 leads, typically V3, V6, I333, measured 80 milliseconds after the J point in the absence of any secondary cause like LVH or drugs. 2. Often accompanied by ST segment elevation greater than 0.1 milliV in lead AVR. 3. The ST segment abnormalities must be persistent, with no evidence of normalization over time. 4. The ST segment depression must be exacerbated with exertion. And 5. Evidence of autosomal dominant inheritance family history is key. Differential diagnosis includes Brugada syndrome, which typically causes ST elevation, long QT syndrome, and significantly left main coronary artery disease, which can also cause widespread ST depression, especially with exertion. Ruling out ischemia is critical. The treatment approach is mainly symptomatic at this point, focusing on addressing the patient's clinical symptoms like palpitations or syncope.
ICD implantation might be considered for patients who face recurrent syncopal episodes or are deemed to be at high risk for severe arrhythmias based on family history or Holter findings, but risk stratification is still evolving for this new syndrome.
From a functional electrical disorder to a cardiocutaneous one, let's explore Naxos disease again, but maybe focus a bit more on the details. It's a rare autosomal recessive disorder with both heart and skin manifestations.
Exactly. Naxos disease, as we touched on, combines cardiac and cutaneous manifestations. It was first described in 1986 in those 4 families from the Greek island of Naxos. Its estimated prevalence is approximately 0.01%, very geographically linked initially.
And the genetic and cellular basis again, linking heart and skin.
Naxos disease is an autosomal recessive disorder caused by a specific deletion in the junction plakoglobin, JUP gene, on chromosome 17. JUP encodes plakoglobin, that key component of desmosomes and adherens junctions, facilitating cell adhesion in cardiac and epithelial tissues. Mutations lead to apoptosis, cell death, of cardiomyocytes and their replacement by fibrofatty tissue, contributing to arrhythmogenic cardiomyopathy. The disease primarily affects the right ventricle with transmural full-thickness fibrofatty replacement, though the left ventricle may also be involved to varying degrees. From early life, most patients present with that curly and woolly hair, which many authors suggest is an indicator of poor cardiovascular prognosis. Eyebrows and eyelashes may also be pronounced. Cutaneous lesions typically appear within the first 2 years of life, on the palms and soles, palmoplantar keratoderma, initially sparing dorsal areas before gradually spreading diffusely. Their well-defined borders aid in differential diagnosis. Some patients are born with shorter limbs, along with curved nails and dental anomalies.
Syncope and sustained ventricular tachycardia are common, with about 33% developing symptoms before age 30. In some cases, SCD may be the initial presentation. The cardiomyopathy can progress gradually or follow hot phases, sudden episodes of ventricular tachycardia accompanied by structural deterioration, sometimes resembling acute myocarditis.
What are the distinctive ECG abnormalities in Naxos disease?
ECG abnormalities are common in symptomatic patients, with about 90% displaying changes. These include negative T waves in leads V1, V3, or V1 to V6, a hallmark of right ventricular pathology. And those epsilon waves, the small, low-amplitude positive deflections occurring after the QRS complex and before the T wave, are present in about 38% of cases and are highly specific when seen. Ventricular tachycardia with a complete left bundle branch block, LBBB pattern originating from the right ventricle, is frequent, while atrial fibrillation has been reported in a minority of cases. Transthoracic ultrasound frequently reveals a dilated RV outflow tract, often with an RV aneurysm and kinetic abnormalities, particularly in the lateral wall of the RV. CMR assesses fibrosis extent and arrhythmia risk. Genetic testing is recommended to confirm the diagnosis in patients and family members. Myocardial biopsy is rarely performed today, but may be used in inconclusive cases.
How are all these diverse findings put together for a diagnosis?
Since Naxos disease is a genetic form of arrhythmogenic right ventricular cardiomyopathy, ARVC,
The 2024 Revised International Task Force Criteria for ARVC, published by Corrado and colleagues, are applicable. Major criteria include regional RV kinetic abnormalities with RV systolic dysfunction or global dilation, histological evidence of fibrofatty replacement, specific ECG findings like inverted T waves in V1, V3, or epsilon waves, and genetic confirmation, for example, the JUP mutation. Minor criteria include isolated regional RV kinetic abnormalities, gadolinium enhancement on CMR, other specific ECG modifications like prolonged S-wave, upstroke, different ventricular arrhythmia presentations, and various genetic and family history elements. It's important to differentiate from other arrhythmogenic cardiomyopathies with right or biventricular involvement, Carvajal syndrome, which we'll discuss next, and acute myocarditis. Patients should avoid strenuous physical exertion. Beta blockers and flecainide are commonly used for antiarrhythmic management, though amiodarone remains controversial due to potential side effects. Catheter ablation may be considered for refractory ventricular tachycardia, targeting areas of scar.
Heart failure treatment should follow current European Society of Cardiology guidelines. And in end-stage disease, heart transplantation may be an option. 2-second quiet.
And finally, we have Carvajal syndrome. This sounds like a close relative of Naxos disease, but with its own distinct characteristics and challenges.
It is indeed a close relative. Carvajal syndrome is a syndromic form of desmoplakin, DSP, cardiomyopathy, making it another cardiocutaneous disorder closely resembling Naxos disease. However, it was identified nearly a decade later, first described in 1998 in Indian and Ecuadorian populations. It follows either an autosomal recessive or sometimes an autosomal dominant inheritance pattern and is associated with mutations in at least 3 known genes, primarily DSP. Its prevalence remains unknown. A key difference from Naxos disease is that Carvajal syndrome primarily affects the left ventricle, with minimal or no right ventricular involvement. It also carries a high risk of arrhythmias and sudden cardiac death.
What's the genetic link here, and how does it specifically target the left ventricle more than the right?
Carvajal syndrome is primarily associated with mutations in the DSP gene located on chromosome 6p24, which encodes the desmoplakin protein. DSP serves as a crucial anchor linking other desmosomal proteins like plakoglobin to the intermediate desmin filaments within the cell's cytoskeleton. It's essential for structural integrity in cardiac and epithelial tissues under stress. Additionally, mutations in desmocolin 2 and plakophilin 2 have also been identified in some cases. While the exact mechanism for the left ventricular predominance isn't fully understood, myocardial injury appears to precede the onset of arrhythmias and heart failure, supporting the hypothesis that left ventricular fibrosis occurs before significant dilation happens. Perhaps the mechanical stress patterns in the LV make it more vulnerable to DSP mutations. Clinically, patients present with woolly, friable hair from birth, similar to Naxos. By around 2 years of age, they develop palmoplantar keratoderma, thickened skin on palms and soles. But here it's distinct from Naxos disease by being striate, appearing as lines or streaks, rather than diffuse thickening.
Some reports also describe linear skin keratosis in flexural regions, like elbows and knees, and follicular involvement on limbs and trunk. Vesicles and bullae, blisters, may appear on the torso, and other features can include nail clubbing, leukonychia, white spots on nails, and dental anomalies. In one study, over half of the patients reported no cardiovascular symptoms initially. Among those who were symptomatic, palpitations were the most common complaint, nearly 4 out of 5, followed by chest pain, 44%, with 39% reporting myocarditis-like chest pain during those hot phases. The initial presentation can be aborted cardiac arrest in 4% of cases, and disturbingly, sudden cardiac death is the very first manifestation in 10%.
How does this left ventricular focus show up on the ECG?
On the ECG, 44% of patients exhibit a low QRS voltage, specifically in the limb leads, OR3, AVR, AVL, AVF, while about 22% present with T-wave inversions in the lateral precordial leads, V4, V6. The study found that inverted T-waves in V4, V6 had prognostic significance, aiding in early disease identification even before structural abnormalities appeared on echo. These low QRS limb-led voltages and lateral T-wave inversions are characteristic features suggesting left ventricular cardiomyopathy and play a key role in differentiating it from typical dilated cardiomyopathy or right predominant ARVC like Naxos. Polymorphic premature ventricular contractions were seen in 72% of patients. Although uncommon, both left and right bedal branch blocks may occur. Paraclinically, troponin levels can rise during the hot phases, reflecting myocardial injury. Echocardiography may not detect early-stage disease, as fibrosis is often confined to the outer epicardial layer initially, with reductions in LVEF appearing later. Coronary angiography is often performed to rule out other causes of angina or LV dysfunction. CMR is considered the gold standard for diagnosis.
A key study demonstrated that Carvajal syndrome patients exhibit a characteristic ring-like pattern of late gadolinium enhancement, LGE. localized to the subepicardial layer of the left ventricle. This pattern is highly suggestive. Genetic testing for the DSP gene and potentially others is vital for confirming the diagnosis and differentiating it from other cardiomyopathies. Endomyocardial biopsy is rarely performed and often conducted post-mortem. Studies have showcased hypertrophic myocytes and fibrosis in the endocardium and interstitium.
Is there a specific set of diagnostic criteria for Carvajal syndrome?
Since it's considered an arrhythmogenic cardiomyopathy primarily affecting the left ventricle, the 2024 revised International Task Force criteria for arrhythmogenic cardiomyopathy of the left ventricular phenotype may be applied. Major criteria here include that characteristic ring pattern LGE involving more than 3 left ventricular segments and low QRS amplitude in the limb leads, excluding other causes. Minor criteria include global LV systolic dysfunction, regional LGE in specific walls, T-wave inversions in V4-V6, excluding LBBB, a high burden of PBCs with RBBB morphology, suggesting LV origin, sustained or non-sustained VT with RDBB morphology, and a history of aborted cardiac arrest or family history. Differential diagnosis includes Naxos disease, RV predominant, different gene, acute myocarditis, which can cause LGE but usually in a different pattern, and other forms of arrhythmogenic cardiomyopathy with LV or biventricular involvement. A study found that exercise exacerbates myocardial injury in Carvajal syndrome, so endurance exercise should definitely be avoided in affected patients and even carriers of the mutation.
Management includes arrhythmia control, beta blockers, possibly antiarrhythmics like sotalol or amiodarone, standard heart failure treatment, and sudden cardiac death prevention through ICE implantation, as the prognosis without intervention is generally poor, especially once symptoms develop. 2-second quiet.
Let's consider a final scenario that truly ties together the need for this kind of vigilance we've been talking about today. Imagine a seemingly healthy 25-year-old man, a dedicated competitive athlete who is undergoing a routine pre-participation physical. His ECG shows very subtle, persistent ST segment depression in leads V2, V6. What's even stranger is that this depression worsens during a stress test. He has no history of chest pain or any other typical cardiac symptoms that would suggest, say, coronary artery disease. Without the kind of deep dive we've had today into unusual ECG patterns, this subtle finding might easily be dismissed as an anomaly, or perhaps misattributed. But because of our discussion and the insights we've shared, this pattern immediately flags a concern for something like Bungard syndrome.
This case perfectly illustrates the core importance of what we've been discussing. It's about recognizing these subtle yet incredibly specific electrical patterns that can be the only early warning sign of a potentially life-threatening inherited arrhythmia. Even in seemingly asymptomatic individuals, these ECG findings are precious clues. It underscores that being well-informed about these rare syndromes is not merely an academic exercise. It is profoundly, clinically critical for early detection and intervention, and it can quite literally save a life. It turns a seemingly insignificant detail into a vital piece of the puzzle. 2-second quiet. So what are the most crucial takeaways from our deep dive into these rare and often under-recognized ECG syndromes today? What should people really remember? Well, there are a few key points I hope our listeners will carry with them. First, the ECG is still a cornerstone, but nuance is absolutely key. The electrocardiogram remains fundamental, no doubt, but its full diagnostic power is truly unlocked only when clinicians and informed individuals like you are aware of and can recognize these subtle and often atypical patterns. Many of these rare syndromes present with unique electrical signatures that, once learned, can be incredibly indicative.
Right, it's not just about the big obvious things.
Second, look beyond the common. While common cardiac emergencies are very well understood, these rare syndromes, despite their lower prevalence, carry a disproportionately high risk of sudden cardiac death, especially in seemingly healthy young individuals or those without obvious symptoms. Awareness is the very first step in prevention. Third, embrace those multi-systemic connections. As we've seen with conditions like Jervell and Lange-Nielsen or Naxos or Danon disease, the heart's electrical health is often intricately intertwined with other organ systems. Features like congenital deafness, unique facial characteristics, specific skin conditions, or even muscle weakness can be vital clues. When you combine those with careful ECG findings, they can point directly to a specific, otherwise hidden diagnosis. It's about connecting seemingly disparate pieces.
Connecting the dots.
Fourth, genetic testing is transformative. For many of these inherited conditions, genetic testing plays an absolutely crucial role. It not only helps confirm a diagnosis, but is also vital for guiding risk stratification, understanding how severe the condition might be, and for effective family screening. This moves us from simply managing symptoms to providing personalized and truly preventative care.
That's huge for families.
Fifth, proactive management is life-saving. From the use of specific medications like beta blockers to life-saving devices like ICDs to necessary lifestyle modifications and sometimes specialized surgeries. Early and appropriate intervention based on an accurate diagnosis can profoundly alter the natural history of these challenging conditions and significantly improve patient outcomes. It's the difference between a tragic unknown and a manageable condition.
Okay.
And finally, the power of detailed history and comprehensive evaluation. A thorough personal and family medical history combined with meticulous ECG interpretation and targeted additional investigations is absolutely essential. Is how clinicians truly connect those dots, avoid misdiagnosis, and ensure that treatment isn't delayed, ultimately making a tangible difference in patients' lives. 2-second quiet.
Now, let's test your knowledge from today's deep dive with a few multiple-choice questions. No pressure, just a chance to reinforce what you've learned and see what stuck.
Exactly. Remember, these are based purely on the fascinating facts we've just unpacked and are designed to make you think about those unique aspects of each syndrome. Question 1. Which ECG syndrome is characterized by a triad of periodic paralysis, ventricular arrhythmias, and distinctive facial or skeletal dysmorphisms, and where the QTC interval may even be normal? A. Timothy syndrome. B. Anderson-Tawil syndrome. C. Short QT syndrome. Bungard syndrome.
The triad.
Question 2. In which syndrome is the hallmark ECG finding a markedly prolonged QTC, typically exceeding 500 meters, often alongside profound congenital bilateral sensorineural hearing loss? A. Romano-Ward syndrome. B. Long QT syndrome type 3C, Jervell and Lange-Nielsen syndrome. D. Noonan syndrome.
Prolonged QTC plus deafness.
Question 3. What is a common and distinctive non-cardiac feature of Naxos disease that often appears from birth and is suggested to indicate a poor cardiovascular prognosis? A. Prominent ear tags. B. Curly and woolly hair. C. Blue sclera. Hypoplastic mandible.
The hair thing.
Question 4. BRASH syndrome involves a dangerous cycle where acute kidney injury and hyperkalemia exacerbate bradycardia due to the synergistic effects of which class of common heart medications? A. Statins. B. Antibiotics. C. And AV nodal blockers. Anticoagulants.
Vicious cycle.
Question 5. Which syndrome is characterized by a shortened QTC interval that shows inadequate prolongation during bradycardia and excessive shortening during tachycardia, a phenomenon known as pseudonormalization? A. Long QT syndrome. B. Brugada syndrome.
Yeah.
Short QT syndrome. Early repolarization syndrome.
The QTC not adapting right.
Question 6. What unique and characteristic ECG finding can be observed in Anderson-Tawil syndrome even when the overall QTC duration is not dramatically prolonged? Deep S waves in V1, V3. Prominent U waves in leads V2, VC. Markedly short PR interval. D. ST segment elevation in lead AVR.
ATS. Besides the QTC.
Question 7. Which characteristic ECG finding is often observed in Noonan syndrome, potentially independent of underlying structural heart defects, making it a unique electrical marker? A. Right axis deviation. B. Abnormal RS ratio over the electroprecordium. C. Markedly short PR interval. D. Deep S waves in V1, V3.
Noonan's specific ECG trait.
Question 8. In long QT syndrome, what is the most common life-threatening arrhythmia, often described as twisting of the points on the ECG, and typically triggered by a long-short sequence? A. Atrial fibrillation. B. Ventricular fibrillation. C. Torsades de pointes. D. Supraventricular tachycardia.
The twisting one.
Question 9. For patients with short QT syndrome, what is considered the cornerstone of management due to the high risk of sudden cardiac death? A. Daily aspirin therapy. B. Long-term oral antiarrhythmic drugs only. C. Implantable cardioverter defibrillator, ICD therapy. A. Cardiac ablation as first-line treatment.
Managing SQTS risk.
Question 10. Which genetic condition, characterized by distinctive physical features and congenital heart defects, affects the critical RAS-MAPK signaling pathway, essential for cellular growth and organ development? A. Jervell and Lange-Nielsen syndrome. B. Anderson-Tawil syndrome. C. Noonan syndrome. D. Naxos disease.
The pathway one. Okay, let's reveal the answers. How did everyone do?
All right, here we go. 1B, Anderson-Tawil syndrome. That's the one with the classic triad of periodic paralysis, arrhythmias, and dysmorphic features. And remember, the QTC might be normal or only mildly prolonged. 2C, Jervell and Lange-Nielsen syndrome. This is the autosomal recessive condition combining profound congenital deafness with that markedly prolonged QTC, usually over 500 meters. 3B, curly and woolly hair. This distinctive hair texture from birth is a key feature of Naxos disease and is thought to correlate with cardiovascular risk. 4C, AV nodal blockers.
BRASH syndrome is specifically about the dangerous interaction between AV nodal blockers like beta blockers and A key hyperkalemia. 5C. Short QT syndrome. That failure of the QTC to adapt properly to the heart rate changes pseudonormalization is a hallmark of SQTS. 6B. Prominent U waves in leads V2, V4. These prominent U waves are a very characteristic ECG finding in ATS, often more helpful than the QTC duration itself. 7B. Abnormal RS ratio over the left precordium. Along with left axis deviation, this is a distinctive ECG feature often seen in Noonan syndrome, potentially independent of structural heart issues. 8C. Torsades points.
TDP is the classic, dangerous polymorphic ventricular tachycardia associated with long QT syndrome. 9C. Implantable cardioverter defibrillator, ICD therapy. Given the very high risk of sudden death in SQTS, ICDs are the primary preventative strategy. 10C. Noonan syndrome. This condition stems from mutations affecting the crucial RAS-MAP-Kaplan-Meier signaling pathway, leading to its wide range of developmental effects. 2-second quiet.
That brings us to the end and another enlightening deep dive. Wow. We've journeyed through complex genetic channelopathies, explored conditions where the body systems intertwine in really unexpected ways, and even touched on acute compounding medical emergencies, all with the humble ECG as our guide, revealing these hidden stories.
Our sincere hope is that this deep dive has not only informed you, but also equips you with a heightened awareness. Understanding these rare syndromes is truly crucial because timely recognition and appropriate intervention can genuinely save lives, particularly in those individuals who might otherwise be dismissed as seemingly healthy until, well, tragic event occurs. It's really about empowering you with knowledge.
It truly underscores that the human body, especially the heart, is full of incredible complexities and hidden stories just waiting for a closer look. So what's a provocative thought to leave our listener with today? Something for them to mull over long after this deep dive ends.
Consider this. If a simple electrical tracing of the heart can reveal such profound and life-altering secrets, pointing to conditions that can mean the difference between life and death, what other subtle signals in our lives, both personal and professional, might we be overlooking that hold equally vital insights, simply waiting for our deeper attention?
A powerful thought indeed. Thank you for joining us on this deep dive. We look forward to exploring more fascinating topics with you next time.